I'm very pleased to welcome our two distinguished guest speakers today. We're going to hear from Dr. Richard Wahl, who is the Elizabeth E. Mallinckrodt Professor and Head of Radiology at Washington University School of Medicine in St. Louis, Missouri. Dr. Wahl is currently the president of SNMMI, and he previously served for several years as chairman of our research and discovery domain, which really helps to promote the development of innovative diagnostics and therapies for patients. We also will welcome Dr. Gary Ulaner, who is the James and Pamela Muzzy Endowed Chair of Molecular Imaging and Therapy at the Hoag Family Center Institute in Newport Beach, California, and is professor of radiology and translational genomics at the University of Southern California. Dr. Ulaner has been the principal investigator of prospective clinical trials for 6 novel PET radiotracers for patients with breast cancer, prostate cancer, and myeloma. Myeloma, and his clinical trials emphasize targeted imaging to guide targeted therapy of cancer. He serves on the scientific advisory boards of Imaginab, GE Healthcare, and the Lobular Breast Cancer Alliance. And with that, I'll turn this over to Dr. Wahl.
Yeah, hi. Thanks. Really good to be with you today. We'll talk a little bit about nuclear medicine, just ever so slightly, so in case you're not familiar with it. Then Dr. Ulaner will talk about FES and its role in diagnosing breast cancer. Then I'll talk to you more. I'll rejoin and talk about some of the challenges with reimbursement for some of our novel therapies and imaging agents in particular. And then talk about how we want to approach this. We think there's a solution. It's called the FIND Act, Facilitating Innovative Nuclear Diagnostics, and how you might join in helping in advocacy. And also we'll have some time for some questions and answers. Next slide, please. In brief, nuclear medicine is really one of the key elements of precision medicine, that is getting the right diagnosis so that we can do the right therapy on a specific patient. So it's really precision medicine, and this lets us look inside the patient to see what's going on using a couple of techniques, single photon imaging, SPECT, and PET scanning. Over 20 million Americans benefit from nuclear medicine procedures annually. The vast majority right now are diagnostic, but there also are therapeutic nuclear medicine procedures, which are a topic for discussion probably on a separate webinar. But these diagnostic radiopharmaceuticals, they're the radioactive agents we inject, and they will target to a variety of normal structures and disease. And we can look at normal organ function, but we can also tell if there's malfunction of organs or tissues. So we can apply this in a variety of settings. One of the very common ones is cardiovascular disease, looking at how the heart is perfused. Also Alzheimer's disease. We can tell if patients have amyloid deposition, which is a sign of Alzheimer's disease. Parkinson's disease, movement disorders, being able to separate patients with tremor from Parkinson's disease. And for today's purposes, we're going to focus a lot on cancer, including breast cancer, but also prostate cancer and neuroendocrine tumors. Those are other areas we study. Next, please.
So actually, now we're going to move on to Dr. Ulaner's slides.
Yes, next is Dr. Ulaner. Thank you.
Yeah.
And while we're doing the transition, there's a couple of points I wanted to make. The amount radioactivity in nuclear medicine may sound a little scary, but the amounts of radioactivity we inject for diagnostic procedures is very low. And these procedures are typically without side effects. It's a very minimum radiation dose. And the cameras we use are very sensitive to detecting small amounts of radioactivity. So I want to make it clear that diagnostic procedures are safe. Not everything nuclear is unsafe. And I think Dr. Ulaner will expand on some of the very productive applications of nuclear imaging. Gary, go ahead.
Thank you so much, Dr. Wahl, and I want to thank Dr. Wahl for inviting me to speak with him today. One of the important innovative nuclear diagnostic agents that is making a large impact today is known as fluoroestradiol, or Cerianna. And this is an estrogen receptor targeted nuclear imaging technique, which I'll be discussing today. disclosures, and then I also like to disclose that I do a lot of teaching with my children, Ilya and Annabelle, that help me as I discuss molecular imaging. So we're talking today about estrogen receptor targeted imaging. And this is a model for how these nuclear diagnostic agents work. We have a target cell. In this case, is going to be the breast cancer cell. And on that target cell, they express targets. In this case, the target is estrogen receptor. We can design keys that bind to those targets, much like a key fitting into a lock. The binding agent for estradiol is estrogen, which is physiologically available, found in all of our bodies. And the estrogen has been linked to a radioisotope, in this case, something called fluorine-18, that emits a small amount of radiation, detectable, but even though it's small, it's detectable on sensitive medical imaging equipment such as PET scanners, and allows us to make exquisite images depicting where estrogen receptor is present and where it is not. And because the estrogen receptor is being expressed on estrogen receptor positive breast cancer cells, this allows us a very sensitive technique for detecting extent of breast cancer. There's been a long history of research in this field of estrogen receptor targeted imaging, which I'd like to, in the sake of time, briefly summarize by saying that this agent, fluoroestradiol, or FES, allows non-invasive whole body assessment of functional estrogen receptor. And it's very important to note that FES is not FDG. So when people are talking about ordering PET scans, it is becoming more and more critical to identify what type of PET scan you are ordering or talking about, because FES, which measures the estrogen receptor, is not the same thing and does not give you the same information as the more common FDG PET scan, which measures metabolism. Here is just a few of the really important clinical applications of FES-PET, this innovative nuclear diagnostic. I'm going to spend most of the time on the first one, which is determining functional estrogen receptor in lesions to help determine which patients should receive hormonal therapy. And this work was really pioneered by Drs. Mortimer and Dadashti at Washington University in St. Louis, where Dr. Wahl is currently the chair of radiology. This is work from Dr. Mortimer and Dadashti, a very seminal work demonstrating if you measure the extent of uptake of FES in lesions for patients who are all estrogen receptor positive breast cancer going on endocrine therapy, and then track patients to see which ones respond and which ones do not respond, we can see that when there is uptake of the FES, so that means that there is functional estrogen receptor, patients may respond, some don't respond, but the majority respond. But I think more importantly, if there is not substantial uptake of the FES on those images, you can reliably say that these patients will be non-responders, and that's critically important. So patients who are on first-line hormonal therapies, if they progress, you're faced with a dilemma. Do you give them a second-line hormonal therapy, or do you move to something else? And this one imaging test, FES, can identify the patients who will not respond to a second-line hormonal therapy and therefore need to move on to a different form of therapy. That can save thousands or tens of thousands of women from receiving ineffective therapy and more quickly move them to more effective therapies. Just a few examples of this: patient with multiple lesions and known to be progressing. However, there is no uptake of the FES in those lesions. This on that graph presented by Drs. Mortimer and Dadashti shows that this patient is down here, will not respond to estrogen receptor targeted therapy. This is a patient that should undergo other forms of therapy because estrogen receptor targeted therapy is not going to be effective. On the contrary, a patient with progressing disease and the lesions are FES avid. This patient is up here on this aspect of the graph. This is a patient who very likely will benefit from hormonal therapies, and hormonal therapy is appropriate. There has now been at least 17 manuscripts demonstrating that that FES could be used to predict response of endocrine therapy in these patients. A tremendous amount of data has been accumulated for this clinical application of FES. A little more briefly, I'll discuss a few other potential applications of FES imaging. One is to assess estrogen receptor status in patients and lesions that are difficult to biopsy. This is an example from Dr. Kurlan in a patient who demonstrated new lesions within the brain. This would have been a lesion that would be very difficult or potentially very morbid to attempt to biopsy. But here the FES-PET could be used to non-invasively evaluate this lesion and show that, yes, it expresses functional estrogen receptor. This is almost certainly from an estrogen receptor expressing malignancy. Another potential application is when you have inconclusive results on conventional imaging, can you use FES to solve these problems, these inconclusive findings? And the answer appears to be yes. This is a retrospective study out of the Netherlands demonstrating that when patients have these questionable lesions on what we call conventional imaging, such as bone scans or CT scans, the FES-PET can answer more definitively, this is a problem such as a metastasis that needs to be addressed, or it is benign. This is not a current approved indication of FES, but is an area of research, evaluation of extent of ER-positive disease. This is a clinical trial that we have ongoing at the Hoag Family Cancer Institute of using FES in patients that are locally advanced at initial diagnosis or have a suspicion for a breast cancer recurrence. And the FES is being compared against standard of care imaging, either CT bone scan or the more traditional FES-PET CT. And in the sake of time, I won't go through all the data, but to say that it appears that FES is as good as or potentially better than what we currently call standard of care for these clinical applications in women with estrogen receptor positive breast cancer. One or two examples from that clinical trial: a woman with advanced local disease where they already knew about the breast and axillary nodal disease. CT and bone scan did not show any evidence of distant metastases, but the FES-PET unfortunately demonstrated multiple sites of osseous metastases, which were then biopsy proven. And now this is bad news for the patient, that they have more disease than they originally believed, but the disease is there whether you know about it or not, and the knowledge that the disease is there allows this patient to receive the most effective therapy with the fewest side effects, which is incredibly important in their care. An example from the second group of patients, those with a suspected recurrence, an FDG PET scan possibly demonstrated a small chest wall recurrence, but the FES-PET demonstrated, unfortunately, more than 20 sites of soft tissue and osseous disease. Again, we never like it when we detect more disease than what was previously thought. However, knowledge of what's there is critically important in order for patients to receive the best therapy. That patient was a patient with lobular breast cancer, and I'd just like to take a moment to note that lobular breast cancer is not the same as ductal, the more common ductal breast cancer, and the Lobular Breast Cancer Alliance is doing an outstanding job of educating patients, clinicians, and the public of these differences. FES has been shown in retrospective studies to be better able to detect disease, distant metastases in patients with lobular breast cancer than the more commonly utilized FDG. And there are prospective trials evaluating this to see if this will be another clinical application. Finally, FES is not just providing direct care to patients, It's also indirectly helping the care of breast cancer patients by helping to develop novel ER-targeted therapies, which are in development. These are two patients undergoing a early phase clinical trial of a new agent that is directed at the estrogen receptor. They both have estrogen receptor positive disease in the spine. But one patient on therapy has a dosage of medication which entirely abrogates estrogen receptor signaling, demonstrating that this drug has done its job. Whereas in this patient, there's a decrease, but not entire resolution of the estrogen receptor avidity of imaging, demonstrating that this patient likely needs a higher dose of the medication in order to be efficacious. And this is now an application of FES where we can use it to chart what doses of medicine are not effective and what doses of medicines will be effective in order to maximize the effectiveness of these new medications being developed and minimize side effects, because you don't have to go to higher dosages in order to get the biological effect. So this is just a very brief summary of what is FES. It's a molecular imaging agent, one of these innovative novel diagnostic agents that allows imaging of the estrogen receptor. This is newly FDA approved under the name Cerianna and is a growing tool for the care of breast cancer patients. And then what can we use FES for? I think primarily right now, this can be used to help thousands or tens of thousands of patients, help select whether they are going to or not going to benefit from hormonal therapy. And there are a whole host of other known and developing indications for FES. So this is just one novel nuclear therapeutic with tremendous impact in patient care. And with the development of the multiple other novel agents for breast cancer, prostate cancer, myeloma, and a whole host of other diseases, this is a field of tremendous impact to patient care. Thank you so much, and I will turn this back over to Dr. Wahl.
Yeah, thanks, Gary. That was excellent. We'll switch over the slides here. So you've heard how exciting it is to have these new imaging agents. And the good news is right now, Medicare is paying for most of these new imaging agents, but they only pay for a little while. And I'd like to talk about that because it can limit access to these innovative agents. So the reimbursement challenge we face with innovative radiopharmaceuticals, I'll outline here. This is pretty technical, but you'll get the idea of what's needed by the end. So there was this Medicare Modernization Act of 2003, and Congress designated all radiopharmaceuticals as drugs. The Cerianna, again, is the trade name for FES, and of course this we think would be a radiopharmaceutical like a drug. And Medicare paid for diagnostic radiopharmaceuticals separately at that time. But in 2008, Medicare and Medicaid Services, CMS, interpreted that the Medicare Modernization Act criteria had expired. And what they started to do then is began bundling diagnostic radiopharmaceuticals with the scan itself, so the radiopharmaceutical and the scan, and treating the radiopharmaceutical, which is a highly specific agent, as was pointed out in many instances, as a supply. Typically, supplies are reimbursed at lower rates than pharmaceuticals. Next, please. So the problem is this has a direct effect on patient access. So many of the newer precision diagnostic radiopharmaceuticals are used in relatively small patient populations, but their costs are average with millions of higher volume, lower cost diagnostic drugs. And what that does is it, as a supply, results in insufficient reimbursement for the precision diagnostic drugs. So some numbers we have say that the reimbursement is actually 9% of the total cost of the radiopharmaceutical. So this is, it's hard to have a good business model if you're a hospital when you do a scan and you only get paid 9% of what the radiopharmaceutical costs. So hospitals must choose sometimes the most appropriate test It means you're significantly underpaid. Some hospitals, you just can't lose money forever or infinitely, so have stopped performing some of these nuclear medicine imaging tests, and patients may not be able to get the scan in their area. They might have to go to another site that is doing it. But what it can fundamentally do is limit access for patients to these innovative radiopharmaceutical diagnostic agents when they're bundled. The impact on innovation, obviously, is that if there is inadequate reimbursement for the radiopharmaceuticals, pharmaceutical developers tend to avoid investing because the business models aren't very attractive. So this is challenging. Next slide, please. So just for a period of 2 or 3 years after these radiopharmaceuticals are introduced, there is a period where there is some so-called pass-through payment. So what happens is there's a brief period of time when the drugs are paid for essentially at their cost, but then there's a reimbursement cliff that comes into effect where this something like 9% of the actual costs are reimbursed, and that's the problem we've been trying to address. So the FIND Act, which I introduced at the beginning for innovative nuclear diagnostics, was introduced in a bipartisan manner this past year in both the House and the Senate. You see the sponsors listed above. And what this does is a legislative solution to instruct CMS on an approach that should help correct this problem of under reimbursement and lack of access. It creates equity in the payment system by requiring Medicare to pay separately for diagnostic radiopharmaceuticals that cost per day over $500. And this only applies to these innovative drugs approved by the FDA after January of 2008. That was the period of time when CMS implemented the bundled payment. Importantly, this is budget neutral. There's no increased cost in radiopharmaceutical budgets to do this as it's arranged. And it would ensure that patients receive medically appropriate nuclear medicine tests that provide the most accurate diagnosis and treatment. It also has a provision that holds the patient harmless for a copay on the drug, which also is something that could, an imaging drug, and this could also improve access for patients. Next, please. So this legislation can take a while. Where are we right now? Well, we know the wheels in Washington sometimes turn slowly, but the bills are in committee, in the Senate Finance Committee, in the House Ways and Means Committee, and the Energy and Commerce Committees. As I said, the bills are bipartisan. There are 22 co-sponsors in the House and 3 in the Senate. There are over 70 supporting organizations, and some of them will be listed on the next page. I mean, the Alamo Breast Cancer Foundation, Force, among others. Next, please. So we clearly need more legislative sponsors, and we need more advocacy groups as sponsors, with the help of patients who are informed as to how they can benefit from these precision therapies. Typically, what can be done is virtual fly-ins can be performed with House and Senate members, additional briefings. There are letter writing campaigns and also the possibility of patient stories, blogs, and op-eds to help inform the public as to what the issue is here. Next, please. So how can you help? As I was saying, engaging Capitol Hill. Congress does listen to constituents, and the patient voice is really critical in achieving passage of the FIND Act. So signing on to our letter as an organizational sponsor for advocacy groups would be critically important and helpful. And we can get you details on how that can be done. Next, please. And as I was saying, an individual letter will also be helpful. We have sample letters available on the SNMMI.org website, and on the upper right, there's a bunch of information about the FIND Act. There are some forms that we can help, that our algorithms help you personalize and send. Next, please. And again, if you're interested participating in a virtual fly-in with your senators and representatives, we want representatives and senators from every state to know about the FIND Act, because it's critically important to have these innovative radiopharmaceuticals made available for patient benefit. Next, please. I just want to say, as someone who's been involved in nuclear medicine for a long time, seeing these radiopharmaceuticals get developed and be able to answer key clinical questions is really exciting. But what is not exciting, and in fact what is quite saddening, is to have these agents available knowing they can help patients, but not have them available due to peculiar reimbursement, which I think is unintentional, but that is the situation we're in. With inadequate reimbursement for many of these agents. So to learn more about this, I see the website here, snmmi.org. It'll direct you to the FIND Act, or else you can do the /FIND Act information. It's a Facilitating Innovative Nuclear Diagnostics Act. I think it's incredibly important. And again, it's not going to raise taxes. It will have a net revenue neutral effect. Next, please. I think that may be our final slide. And I wanted to thank you for your attention. I know that Linda will have the ability to take questions, and we'll try to answer them.
Thank you so much, Dr. Wahl and Dr. Ulaner. We do have time for questions, so if anyone would like to ask any questions of either of our guests, please enter that into the chat. I have a quick question, Dr. Wahl. I think you have participated in some of those virtual fly-ins and the letter writing campaigns, and just wanted to sort of get your, any impression you have of how those go, and why it helps to have a patient on the line at the time.
Well, clearly we haven't passed the bill yet, so we've got some work to do, and as you noticed, there aren't as many Senate sponsors as House. So we need. I think there's a lot of requests of Congress right now in the Senate, and we have to get the congressmen's and women's ear to be able to let them know these problems exist and are real. And I think it's more compelling for a patient who can talk about some of the challenges they face, in terms of treatment selection, some of the issues that they've encountered. I think those are powerful stories. And as professionals, I think we have impact, but I think patients have even greater impact, and organized patients have even greater impact still. But we have to get the message out. We have to broaden our message from a variety of organizations, because while our focus today is breast cancer, the same kind of thing is going to happen in prostate cancer real soon. We already have agents that really work well that are now bundled in, and their use has dropped greatly. The same occurs for patients with suspected dopaminergic disease, all kinds of issues. So there are lots of problems. It's not just cancer. So it's a broad set of issues, and I do believe the visits are incredibly important and worth the effort. Gary may have some other comments on his experience.
I entirely agree. The agents make an immense impact, and we want to do everything that we can in order to keep them available to continue making this immense impact.
Absolutely. All right, so we do have a question. So this is my question is about private insurers. I'm a patient and patient advocate with the Lobular Breast Cancer Organization, MBCA, and Mediviver. I was lucky enough to have the FES scan, and it was helpful. They have Anthem Blue Cross, and they said that no pre-authorization was needed, no code. I was told that means it will be covered, but I haven't gotten a bill yet, so not sure. So I know insurance is always top of mind for the patients. And I see Christina has joined us. Christina Arenas is with our health policy staff and deals a lot with insurers. So I'm not sure who wants to address that question.
I would say thank you for coming forward. I would also say I'm so sorry to hear that you're battling with breast cancer, and I'm very happy that the FES scan was valuable in your care. I think this is more going to be an issue for the hospitals and the providers actually than the patients themselves. The patients, of course, will have to take care of deductibles and co-insurance for their individual insurances. It's the beginning of the year, so if you just had it in the beginning of the year, you may have a larger a copay than later because of meeting those deductibles. I would emphasize this is extremely important for the hospitals, because let's say that the patient might be billed a certain X number of dollars, and the hospital tries to offer that for a certain amount of money, but it will get reimbursed Y amount of dollars. When Y is a slightly greater than X, the hospital can offer the FES scan and other scans, but when Y plummets to a small fraction of what X is, then the hospital ends up losing money every time they do the study. And many hospitals can't afford to do that. And it would become a tragedy if hospitals stopped offering FES or any of these other agents because they say we're losing too much money. We can't stay in business. We can't offer the scan for that one reason. So I don't believe the individual patient is going to see an increase in their or decrease in their charge, but the individual patient is going to feel a tremendous impact whether or not hospitals can continue to offer the study.
And
I might comment, Chris, just beforehand, Medicare right now does cover these scans. So if you have Medicare, my understanding is that currently Medicare doesn't require pre-authorization, at least traditional Medicare. That could change. But I think one of the challenges Christina will talk about is that even though Medicare covers certain things, sometimes the private insurance companies are slower in covering things than Medicare for their beneficiaries. And there's a continual ongoing effort to educate insurance companies about these newer imaging tests. And Christina can talk a little more about society efforts in this space, because they should be covering it, but not all of them know about it. And there may be some tendency for insurance companies not to really quickly adopt new technologies. And I would just say, Christina, you want to talk about our efforts?
Yes. So private insurers negotiate with providers separately. So the coverage could be different from Medicare. The FIND Act operates under Medicare, so the FIND Act wouldn't concern, how private insurers operate. Also, one good thing about the FIND Act is that there is a hold harmless provision, so you wouldn't be responsible for your copay under Medicare if the FIND Act passes. And as Dr. Wahl mentioned, we, on a, monthly basis, we are talking to private insurers. We're trying to get these radiopharmaceuticals covered. We're constantly doing education to make that happen.
thank you. We do have another question. So she says, I consider myself a patient advocate who keeps fairly up to date with cancer diagnostics and treatment across all cancer types, yet I hadn't heard of FES-PET, even though it was approved in May 2020. How common is it for cancer centers across the country to offer FES-PET in addition to FDG-PET, especially in comparison to the institutions that offer FDG-PET? Is this widespread and about to be cut off because of adequate reimbursement, or is it not widespread and is not going to get more widespread because of reimbursement issues?
Rich, do you have an idea of the extent in your area?
Well, I would say that I don't have hard numbers, but FDG is much more widely available than FES. And FES is, I don't have actual figures, but it is a much smaller availability. And I do think that part of the decisions on even whether companies are going to make it, remember, just for the audience, that these drugs Cerianna, the FDG, these are made with fluorine 18, which has a 109-minute half-life. So you have to make them relatively close to where the patient's scan is going to be done, within a couple of hours of driving typically. So a regional cyclotron manufacturing site has to be able to justify that they can make this and sell a few doses and get paid for it before they would take on the regulatory challenge of making it. So I believe that the FES is more widely available in large urban areas at a few hospitals, but I think the economics, as was pointed out wisely by the patient advocate, it makes it less likely that it will disseminate, and if disseminated, less likely it will continue unless we can get this reimbursement issue solved.
I don't have hard data on how prevalent FES is in different hospitals either. Although maybe I'd point out that when FDG was first being utilized, it was only utilized at the academic centers and forefront hospitals. And now, of course, it has proliferated, so it's utilized virtually at every medical center because it's shown such proven value to patients. FES is also going to have that proven value. So I expect, given the right background, that FES will expand exponentially to be utilized at virtually every medical center, if those medical centers have the ability to offer the agent and the ability to financially support it.
Thank you. Just one of the attendees is pointing out that if you go to Cerianna, I guess on their website, maybe they have a map of the states that have it. So that might be another resource for people looking for where it's currently being offered. It is being rolled out and I know it's being offered more and more. So it might be coming to a center near you. I think that's all the questions that we have in the chat. I want to just really thank both of you so much for your time today. This was really informative and helpful. I hope it was helpful for all the attendees. I want to thank you all for attending and for being here and spending a part of your Valentine's Day with us. I hope you all have a wonderful week. And we will be, as I said, posting the recording to this on our website. So I'll be sending out the link, and please feel free to share that link with your communities.
Again, right. I would just say that just remember the SNMMI.org, and you will see the access to the FIND Act on our website. And it would be wonderfully appreciated if you individually or as groups could help support the FIND Act. It really is important, and your voice matters.